Hello everyone, today I am presenting a case regarding Xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis, or XPN, is a rare condition that results in destructive chronic inflammation of the kidneys, where granulomatous tissues with lipid-laden macrophages replace normal renal parenchyma. It often occurs in the setting of staghorn renal calculi. Unilateral form of this disease is rare. Bilateral form is even more so as seen in this case. We present this case due to its rarity and for academic purpose. Patient is a 65 years old African American male with a past medical history of hypertension, type 2 diabetes, and peptic ulcer disease. He was referred for admission by his PCP because of abnormally low hemoglobin and a complaint of shortness of breath. Patient denies any significant review of systems. Vitals on admission were stable. His physical exam showed an uncomfortable patient in moderate distress with abdominal distension. No organomegaly palpated. Lab workup revealed microcytic anemia, acute renal injury, elevated AST and CRP. Urinalysis was also done and showed pyuria with a positive culture of Proteus mirabilis. Patient received 2 transfusions of packed red blood cell and his hemoglobin then stabilized. Due to his worsening kidney function, bilateral kidney ultrasound was done and it showed bilateral polycystic kidneys with parenchymal thickening and staghorn renal calculi as seen in figure 1 and 1.1. CT abdomen pelvis without contrast revealed again enlarged kidneys with bilateral calculi, just like the images seen in the ultrasound. The calyces were dilated with multiloculated appearances given the famous appearances of the bare pore sounds known to be specific for XPN as seen in figure 2. Due to the presence of staghorn calculi, enlarged polycystic kidneys, radiographic images, and worsening kidney functions, presumptive diagnosis of bilateral XPN was made. Bilateral nephrostomy were done to relieve and drain the calyces. CT abdomen pelvis was repeated 1 week later, which, while showed an improved dilated calyces, revealed persistent XPN in both kidneys. Patient was then optimized and prepped for nephrectomy. Right nephrectomy was performed, and the biopsy study confirmed the presence of lipid-laden macrophages with abundant foamy cytoplasm and bland nuclei, as seen in figure 3. Abscess with sheets of neutrophil was also seen. No malignancy cells visualized, as seen in figure 3.1. Left nephrectomy is deferred at patient's request. Figure 2.1 is a CT abdomen pelvis without contrast, status post-right nephrectomy. You can see persistent XPN in the left kidney. In summary, XPN is a rare entity, predominantly a unilateral disease that is associated with renal obstruction with stones and chronic infections of the urinary tract. Pathogenesis is poorly understood, but considered to be related to lipid-laden macrophages. Concomitant infections with E. coli, Proteus mirabilis, or Enterococcus faecalis are common. Differential diagnosis includes renal tumors, pyelonephrosis, infected hydronephrosis, and renal lymphoma. Hence the importance of biopsy study. Radiographic images are important for presumptive diagnosis that needs to be confirmed with biopsy study for the presence of lipid-laden macrophages. Lastly, once the diagnosis of XPN is made, no conservative or medical therapy presently exists. Surgical nephrectomy is, unfortunately, the only non-curative. Thank you.